if you have someone on these medication, most likely pharmacy would be following the patient with you. They are very dose specific, very, very dose specific. And you might be required to draw trough, for vancomycin trough, gentamicin trough. And if you were to see that on your order, kindly follow the time that level needs to be drawn, because doctors and pharmacists will change a patient's dose based on what you draw. Maybe the lab will draw it, but if you see it, then please follow the time. Yes.
So you're trying to maintain the highest, the level that's going to be the most therapeutic to knock down the...
Right.
Okay.
But also because both of them are extremely harmful to the kidney, both vancomycin and aminoglycoside. So if you have an older patient, which we have a number of them, the older patient, they are more sensitive, if you will, to renal medications. So both vancomycin and aminoglycoside, we keep a very close eye on them. Yes.
What is the difference between a peak and a trough? Because they usually
Yes, very interesting. We now mainly draw only troughs at our facility. Peak is to indicate how much it goes up. Most likely, they would want that to be above the MIC, but also that's when the medication takes the most effect. And for aminoglycoside, the peak affects the hearing. So if the peak is beyond the toxic level, the hearing might be impacted. But oftentimes, we don't look at that as much as the trough, because the trough affects the kidney. The trough, how low it dips, is what affects the kidneys. So if the trough is too high, then we need to lower the dose so the kidneys won't be harmed. It's very interesting. It's called pharmacokinetics. But basically, only these two drugs require that type of monitoring. The other ones, you would just pop it in, and it's not dose dependent. It will be more like an aspirin. You pop it in, it works, it's the end. However, well, although penicillin and cephalosporin, we have to keep an eye on the kidney as well, but it's not based on level. Only vancomycin, only aminoglycoside. We must draw appropriately timed levels. So again, if you see that order, even though if you don't have to draw it, the lab has to draw it, please pay attention to it. The next group of antibiotics, they are bacteriostatic. Now, there's the difference between bactericidal and bacteriostatic. Bacteriostatic means they kind of just halt the multiplication of the bacteria. It holds it. It doesn't kill them. Versus bactericidal, it kills the bug. So there is a difference. So bactericidal is always far better than bacteriostatic. Does that make sense? Mm-hmm. So bacteriostatic, then why do we give it? Because it still works. Because oftentimes this group of medicine, they are given with something else. They're not given by itself. For example, clindamycin often is given with levaquin. Clindamycin covers bugs that levaquin doesn't. So it's not given by itself, but it's still super effective if it's given in combination with another agent. Second one is erythromycin, or you hear about azithromycin. They are in the same class of something called macrolide. Erythromycin is an older agent. Azithromycin is Zithromax. Have you heard of Zithromax? Kids take that a lot. Grown-ups take it for pneumonia a lot as well. Erythromycin and azithromycin, not so much azithromycin, but erythromycin interacts with a lot of medicine by stopping the liver enzymes from working. So erythromycin is the type of medicine that inhibits hepatic enzyme. So then it can process toxin as well. So this can increase toxicity of other agents like digoxin. So this is hardly use anymore, but just to know that erythromycin and other agents that ends with mycin can inhibit the liver enzyme. So tetracycline is more for acne and things like that. Doxycycline, that is one group by itself, but they are bacteriostatic. They don't kill the bug necessarily. Now onto the quinolone. The quinolones, they interfere with the DNA, RNA of the bacteria. Rifampin is for same type of thing. It's also inhibit the bacteria's DNA, RNA, so it cannot live. Anti-metabolite are the sulfa and trimethylprim. It inhibits from being metabolite into something else. Okay, and then the virus, we're gonna talk about acyclovir, and INH is for TB. It inhibits something that's needed for TB to grow. It's a very impacted slide. Questions?
You have a few slides on your cephalosporins. What were
This
the
one?
first and second generations, like the examples that
Right.
you have?
So they are cefazolin, CEFAZOLIN. That's one of them. That's NSEF. And second generation would be like your cefoxitin, CEFOXITIN. So just to know there are different generations. The older one covers more gram-positive. The newer one covers more and more gram-negative. So that's just generally.
So the third generations will cover more gram-negative,
That's right.
and
That's
it's
right.
also part of the broad spectrum, right? The third
It's
generation.
part of the broad spectrum, but it's not as a big gun as, say, in mepenol. That's still stronger than that. So it does cover more. For cephalosporin, it's kind of tricky because as it moves towards gram-negative, it loses some of the gram-positive coverage. So third generation is great for, say, E. coli, Pseudomonas, Klebsiella, or your gram-negative stuff. Then it slowly loses the gram-positive, your staphylococcus, your strep, things like that. Does that make sense?
Yeah.
Great question. Okay. Let's see. So these are different ways of how an antibiotic would kill or halt the bacteria. Oops, sorry. There we go. So resistance, we want to not give it if possible, because the more antibiotic the bacteria is exposed to, the more likely they will become resistant to it. So let's say I have a cold. It's caused by a virus. Would an antibiotic work? No. I think physicians sometimes tempted to do something for the patient so they don't feel so miserable. But if you give antibiotic to a patient, a kid, whoever, when they don't need it, you're building up the bacteria's resistance. So when they do need it for later on, for bad pneumonia that they have, it might not work. So ways of ways of the microbes developing resistance. It can be mutation. By mutation, they would change the way they metabolize drugs in their environment, making the drug not effective. So as a matter of fact, do you know the antibiotic Zosyn? Have you heard of that? Zosyn is not a penicillin by itself, it's a piperacillin, but it comes with a substance called tazobactam, Tazobactum. What happened is tazobactam in itself, it inhibits the enzyme that the germs produce to break down the penicillin. Does that make sense? So, so certain medication comes with a substance that stops the enzyme from breaking the penicillin down. Same thing with augmentin. Augmentin may be taken by kids, grown-ups alike for different things. It's amoxicillin, which is something we're familiar with. But amoxicillin sometimes doesn't work itself anymore. We need the enzyme inhibitor called clavulanic to work with it to stop the germs from breaking the amoxicillin down. So together, that's called augmentin. So sometimes they produce enzyme that just breaks the drug, or bacteria has these little pores and channels that absorb things, and just like us, they need nutrition to survive. So some germs have these pores and channels to absorb nutrients from their surrounding. They would close off those pores so the drugs cannot pump into them and kill them. So they would stop uptake via these channels. And then we have drugs that works on that to prevent it. Also, these receptors, let's say the penicillin, it has to work on this particular receptors. It would change the shape of the receptor so it cannot bind to it anymore. Germs are pretty smart in a way, I guess. And decrease the binding so the antibiotics won't work. And then also, it can synthesize things to antagonize the drug. So there's again, if we don't have to give antibiotic, we should not. What can we do? What can we do as a healthcare provider to stop that? To give antibiotic only when we need, not to everybody else. And don't use broad spectrum stuff. Again, if you bring out the big gun the first time, then it will be useless the next time. So use as narrow as possible, narrow spectrum agents as possible. So if the culture comes back gram positive only, you don't need a gram negative drug for that situation. And if your culture comes back, they have bad pneumonia caused by gram negative, you don't have to have the gram positive drug on board. And different things, different disease, they tend to have a certain kind of drug. Like for example, pneumonia oftentimes is gram negative, and in nursing homes, they have those super bugs that you might have heard of. So in those situations, they might need more than just gram negative, and they tend to have more Pseudomonas-like type of infections. And versus if you have a healthy person just going to a gym often, and then they start having these cuts on their skin that won't heal, it turns into cellulitis, then you would think of staphylococci or MRSA, because now even in the community, there are more and more MRSA stands for methicillin-resistant Staphylococcus aureus. What happened is it builds up such an resistance that even the big gun that we just looked at, they might be resistant to it. And that's not good news, because we start to run out of ammunition against these bad bugs. So environmental use of it, oftentimes you might see antibiotic being used in your food. I don't know if you notice certain types of cheese. So read the ingredients. I don't know if you agree with it or not. Either way, minimizing the use of it would help reduce antibiotic resistance, because sometimes they add quite a bit of antibiotic in our food these days.
Oh, I was just going to say that I noticed in shredded cheese they put like an antifungal agent. Yeah.
They have an antibiotic often used in cheese and some other food called natamycin, which is very similar to gentamicin group of medication. So it's a medication. I don't know why they put it in there. I guess to help their food to last longer, or they also put it in the cow itself, not just the cheese, right? So again, it depends on what your opinion is. By all means, if we reduce the usage of antibiotic in general, it would help reduce resistance. Now, one thing, if your patient going home on an antibiotic, remind them to finish the entire course, whether you work in a clinic, hospital, wherever you might be. Finish the course, the entire course of antibiotic therapy is so important. Resistance also comes back if the entire course of antibiotic is not taken, because they study the medicine that it takes 7 to 10 days or 7 to 14 days to kill the most, if not all, the bacteria that's causing the disease, whether it's UTI, pneumonia, whatever the situation is. It's designed to be taken 7 days, 10 days, or 14 days. They must take all of it. Even though after, 3 days or so, the person feels perfectly fine. I'm fine. I don't need to take my antibiotics. Well, if they stop, the germs, it might come back and it will be resistant to the medication that they were taking. So remind your patients, please finish the entire course. Okay, 10 minutes. Cool. So the very careful use is very important. It's up to half the time that antibiotics being used for prophylaxis to prevent an infection. And the judicial use of it would be encouraged, because in a surgical situation, you would want antibiotic on board. And at our hospital, our SCIP guideline, our surgical infection protocol, is to have 3 doses, which is 1 dose prior to incision and 2 doses after. And for prolonged surgical cases, they might even take 1 or 2, a minimum 1 more dose during surgery. So sometimes up to 4 or 5 doses of antibiotic. So that's judicial use. That's not overusing the antibiotic, so long they stop at the 2nd dose post-operatively. Endocarditis, if you have friends who have heart situations, their dentist might recommend them to take that amoxicillin, ampicillin, or similar antibiotic to prevent endocarditis. It's been shown that for patients who have heart conditions with their dental work being done, they are more prone to having cardiac infection post-dental procedures. So in those patients who are susceptible to it, they would need to take preventative antibiotics. For those who are neutropenic, whether they have chemotherapy on board or prolonged period of steroid use, they might have neutropenia, and that would be important for them to take the antibiotics. Sometimes they come back to the hospital with a full-blown infection because they've been taking chemo. Or those who have recurrent UTI. So some people might be more susceptible to UTI and they need chronic usage of that, but there might be other remedies for them as well. So wherever you might practice, be sure you check your SCIP guideline or your infection protocol, because different hospital or different place might have different protocols. So we talked about how they work. Those were the previous slides. Now, renal impairment, again, penicillins, cephalosporins, your vanco, aminoglycosides, and all except one quinolone, they all impact renal function. So except your moxifloxacin, and there's except one penicillin called nafcillin that doesn't affect kidney, and one cephalosporin called ceftriaxone that doesn't affect kidney. Everything else almost always affect the kidney, your sulfur drug, things like that. And we talked about the appropriate level, very important. Please help the patient, not us. But what happens is if the level is drawn too early or too late, it doesn't reflect what's going on in the patient's body, then the doses might be adjusted incorrectly. No antacid with tetracycline and quinolone. We talked about erythromycin with digoxin, bad combo. And again, there's up to 10% of cross-sensitivity between penicillin and cephalosporin allergic patients. Antiviral. Any questions on antibiotics before we go to the virus?
What were the ones that didn't affect the renal? Moxifloxacin and...
Oh, the only ones that don't affect the renal functions are moxifloxacin, the ones that don't, nafcillin, N-A-F-I-C-I-L-L-I-N, ceftriaxone, C-E-F-T-R-I-A-X-O-N-E, and your erythromycin. It doesn't really affect it either. So what are other ones that I talked about? Moxifloxacin, nav, ceftriaxone. Your erythromycin doesn't. But that's about it. Almost everything else, we have to keep an eye on the patient's renal function. Okay. Antiviral. Okay, so antivirus, it's very important. We have virus. We are actually surrounded by virus. I don't know if you're aware of it or not. Our normal immune system will protect us from virus, but those who have suppressed immune system, again, those who might have chemotherapy or prolonged chemotherapy, their immune system will be down. Those with HIV, the immune system will be down. So in addition to just their antivirus that they have, the HIV that they have to fight against, other virus would be possible to overcome their system as well. Antiviral, they end with cyclovir. They are pretty strong medicine. They can be given for herpes zoster. For those who come into a hospital overcome by herpes, can receive these. It comes in a pill form, topical form, but also a cyclovir comes in an IV form. So for those who have viral meningitis, a cyclovir. So that can be given via IV, and it impacts the renal function. So if they have renal disease or just not working right for some reason, their kidneys not working properly, those need to be adjusted. And then on to antiretroviral. You know how regular virus and bacteria reproduce itself is different from retrovirus, correct? Okay, so just so you know, there's a difference. So they work off of RNA instead of DNA. Long story short, they come in these different agents that work on the RNA of the virus. So NRTI, as nucleotide retrovirus transcriptase inhibitor. But basically, the oldest agent is called AZT, Zidovudine. It came out back in the late mid-80s, long time ago. It affects the blood. It drops blood cells like mad, so it doesn't help the patient. But it works back then because that's the only drug they had when AZT first came out for HIV. And then we have other agents, DDI, D40 and DDI, but I didn't include that on this slide. Those are also for antiretroviral. For those who work with AIDS patients, these are very important agents. Lamivudine, Epivir, Abacavir, emtricitabine, tenofovir. Some of them can cause numbing in the fingers and in the nerve. And some of these, again, they can cause pretty bad GI side effect. And some cause weight gain or lipid distribution disorder. So NNRTI is non-nucleotide retroviral transcriptase inhibitor. But they do the same kind of thing. They kill off HIV while suppress the HIV reproduction. That's the main goal. And the goal is to keep them at the minimal. We call the viral low. We don't see them as much as Sequoia, but if you work somewhere in San Francisco, General, or other areas like that, you may see more of these patients. The goal is to drop the viral load to bare minimum. They can cause rash and liver toxicity. A lot of them can. And then PI is the protease inhibitor. So in order for the HIV to bind to the white blood cells, it has to come together, correct? It has to bind to it and infuse itself and all the DNA, RNA material into the white blood cell. That's how it infects the body. So what it does is, for the protease inhibitor, it prevents the virus from fusing to your white blood cell. Pretty cool. And I think it is. So they are the ones that end with Navir, atanzanavir. It's very interesting. This drug was actually used quite a bit, if not first used in Tanzania. So the generic name is atanzanavir. Brand name Reactase. We then have rosamprenavir. Laxavir. They can cause dyslipidemia. It affects lipid metabolism in the body. Bad for blood sugar as well, rash, diarrhea. They can all cause bad rash and diarrhea. Fusion inhibitor, similar to the protease inhibitor. So the last one blocks the protease, the enzyme required for the fusing of the virus and the white cell. This blocks the fusing and the injection of the DNA, RNA material into the white blood cells. Main agent is Maraviroc, brand name Cellsentry, so it stops the entry of the virus into the white cell. That's how I remember that. And the last but not least is integrase. It prevents the integration, the enzyme that incorporating the virus into the white cell. The brand name is Icentris and Reltegravir. So all in all, that's a mouthful. It interacts with a lot of stuff, but anything that ends with vir, you can probably count on it being used for virus. So then we have antifungal in the last minute. Questions on the virus. It's a big topic that really takes a month to talk about all that.
Real quick, which ones are covered? Which one would you give to somebody with the flu that might be immunocompromised for us?
Flu, actually, it's not on here. Flu, we would give Tamiflu. It's called oseltamivir. Brand name is just Tamiflu. Have you heard of Tamiflu? Tamiflu is
That's the only one.
that's the only one. We can try amantadine as well, but it's so Tamiflu is pretty much the only one, and you have to give it within 48 hours, I believe. So that's what would be used for that, but it's also impacting renal function. So I saw another hand somewhere here. Okay, quickly, antiviral. Anything that ends with azole, you see azole, they are antifungal. They are all hepatically metabolized. That means they're metabolized in the liver, can be given peel, topical cream. Orally, we have nicerol, the clotrimazole, and fluconazole is used a lot for yeast infection and other infections. But if they have blood fungal infection, yeah, we see that when I used to practice in Fresno County, we had a lot of farmers, and they often come in with fungal infection in the lungs and in the blood. So we appreciate the fact that we have food, but someone has to work in the farm for that. They would need this not just topically, not just orally, they need it intravenously. So fluconazole works really well for Candida. You heard of Candida albicans? Okay, Candida, it's one of the main that's a bad word, fungi out there. You and I would have no problem fighting off yeast infection and fungal infection. But sometimes if they're ill to begin with or have underlying disease, for example, heart conditions, diabetes, immunocompromised, they are more prone to have fungal infection. Elderly who don't get out much. So these can be used for yeast infection. Cream can be for ethnic food or vaginal infection. They are metabolized in the liver, so it can interact with other stuff. As a matter of fact, ketoconazole is a no-no with picosine. It's on the list of do not give. So azole, if you see azole, it stops or slows down the liver from metabolizing things. So it stops the minion from working. So that's how I remember it. So azole, the antifungal, stops the liver from metabolizing things. So you guys done well choosing to be a nurse. It's a big job and a big task, big responsibility. I'm glad to be part of assisting your learning here. So you choose well, so live well. Questions?
Thank you.
Thank you. Sorry.